So decay or dental caries is a result of bacteria within plaque. They convert sugar within our food and drink into acids that slowly destroy teeth. It affects 1 in 3 people worldwide. And if left untreated, it can sometimes result in death. And then gum disease or periodontal disease is a disease that affects the supporting structures of the teeth, so the gum and the bone. And that's characterized by bleeding gums, swollen gums, pain and bad breath. And in its most severe form, what happens is the gum disintegrates and the teeth can fall out. It's also associated with a number of other diseases, such as cardiovascular diseases and diabetes. So in terms of treatment, it's expensive, as I'm sure you probably know in your home country. It's not usually covered under universal health. In most high-income countries, dental treatment averages about 5% of total oral health expenditure. And in other low and middle-income countries, a lot of the time the government are unable to provide services to the general population to treat these conditions. And so that's why prevention is most important. And I'm sure all of you are aware of a number of measures that we can do to combat these diseases, such as brushing and flossing. And in dentistry, we refer to these as the pillars of prevention. So that's often oral hygiene, a good diet, exposure to fluoride, regular visits to a dentist, and also dental education. And in terms of the current scientific evidence, the preventative approaches are that are most fundamental for preventing these diseases are in removing plaque. So plaque, you may not have seen it or heard about it before, but essentially it's a biofilm. It's a biofilm that sticks to the teeth. It forms in an ordered sequence of events. It results in a structured or functionally organized species of bacteria. And we all have one. We're born with one, and we can't eliminate it in the same as the bacteria within our gut. But what we can do is alter the pathogenic nature of the biofilm to reduce the bioburden and maintain a normal oral flora. And it's generally accepted that mechanical approaches such as brushing and flossing are fundamental for the control of these biofilms. However, even in the best patients, adequate cleaning of hard to reach areas is difficult. And for elderly patients, those with physical and mental limitations, those with mispositioned or isolated teeth or bridges or braces, this is even more difficult. So the alternative is chemical control, and that's an adjunctive method to reduce the biofilm and kind of prevent it accumulating it rather than eradicating it. So various agents have been researched, and these have been incorporated into many oral care products such as mouthwashes, and there's variations on these. They're divided into cosmetic mouthwashes. These really mask bad breath and give a fresh feeling. And then we've got the therapeutic mouthwashes, which by contrast, these have active ingredients which help the mechanical control to maintain oral health. They really act in preventing the initial step of biofilm formation, which is the bacterial adhesion. Beyond that stage, when the bacteria within a complex biofilm, it becomes increasingly difficult for any chemical agent to infiltrate and have a long-lasting effect. So the most researched and the current gold standard mouthwash, therapeutic mouthwash, is chlorhexidine digluconate. The way that works is it binds to bacterial surfaces. It acts against certain bacteria. We call them gram-positive and gram-negative bacteria, and they increase the cellular membrane permeability. And that way they cause rupturing of the cells and they have an antibacterial effect. So although it's considered the gold standard, there are some drawbacks to using this. And if you use it too frequently, it can cause taste disturbances, it can cause hypersensitivities, it can cause soreness or irritation. So what's the alternative, really? And I think that's why, obviously, we're all here today. And a traditional remedy, which originated from India, involves swirling oil around your mouth and then spitting it out. This is known as oil pulling. So it normally involves coconut oil, sunflower oil, sesame oil, and it's becoming increasingly popular in a Western world as well. A lot of the promoters of it say that it can pull out the toxins, which they call AMA, and there's various websites and books, which you can see on the screen, who advocate the use of this to whiten teeth and remove bacteria. And some even go further to suggest that it can heal tooth decay, prevent heart disease, and it can have a powerful and cleansing effect on the mouth and the sinuses of the rest of the body. Now, none of that is evidence-based. In terms of what is evidence, so various hypotheses have discussed the mechanisms by which coconut oil may act on decreasing biofilm accumulation and adhesion. So the mechanism of oil pulling, swishing the oil around your mouth, exerts a mechanical force on that biofilm. So we call that emulsification, and that increases the surface area of the oil, which forms on the tooth surface, and it can reduce adhesion of bacteria and aggregation of the plaque. Additionally, coconut oil is a source of medium fatty chain acids, and the action of these can form different chemicals, which are often found in soap products, and they can cause disintegration of certain bacteria and cell shrinkage. And they can also reduce glycolysis and sugar oxidation by acting in a non-competitive manner with the bacteria in the plaque biofilm. So really it's kind of finding out why it's effective, because coconut oil is accessible to the majority of the world's population, and it is a cheap material for most people. So there is merit in researching this. So the objective of this systematic review, there's been many clinical studies on the use of coconut oil to improve dental health, but there's been no previous systematic reviews bringing all of the research together to assess the effectiveness of this remedy in improving oral health and dental hygiene. So the systematic review was conducted according to the preferred reporting items for systematic reviews and meta-analyses, so the PRISMA guidelines, and it was registered under Implasi. And 6 databases were searched using a comprehensive search strategy, focusing purely on Ayurvedic medicine in conjunction with oral health. The search strategy included appropriate changes in the keywords, which you can see on the screen, and followed the syntax rules for each of the 6 databases. And a comprehensive screening method was employed to ensure precision within the search. This was carried out by multiple authors, where disagreements were resolved by discussion until consensuses were reached. Any studies that were eligible for the inclusion with insufficient information were contacted, and then the results were reported as a narrative description. Unfortunately, we couldn't provide a meta-analysis because of the lack of clinical heterogeneity and differences in the reporting of the data, including studies. In terms of the studies, the last search was performed in June this year. There were no restrictions regarding the year, the time of publication to really maximize the pool of studies. There's also no restrictions on age, gender, sample size, or ethnic origin, and no language restrictions. The only restrictions that we put in place were on animal studies and in vitro studies, or without RCT design. So following the initial search, you can see there was about 1,300 studies that were identified, 1,200 once duplicates removed. We considered 38 studies to be potentially eligible, but after comprehensive screening of these articles, 34 had to be excluded because they didn't meet our inclusion criteria. And the 4 papers were then subsequently analysed for data extraction. So these are the 4 studies here. All the published data describe patients between 2015 and 2019. Total number of study subjects was about 182, and the age range of these were between 6 to 52. The mean age for the subjects was 22.3 years, and all studies used coconut oil as an intervention for their oil pulling study. 3 of them used water as a control, and 1 of them used that chlorhexidine digluconate, as I previously mentioned, as a gold standard. They differed in how they advised the adjustment Some advised using the coconut oil as a mouthwash for 10 minutes without brushing. One study advised using it for 15 to 20 minutes, and the other didn't have any limit set out on that. And the study duration ranged from about 7 to 14 days. In terms of the indices that we got out of the systematic review, a few of them looked at the plaque index. So that's the amount of plaque that's present within the biofilm. There's 2 studies that looked into this. One found a statistically significant difference between using coconut oil and using water. And then the second one, which is Seskin, who used the chlorhexidine, they found that there was a statistically significant difference in reduction of plaque scores for both using oil and chlorhexidine. There was a number of studies that looked at the gingival index, that's the amount of swelling and inflammation of the gums. And they found that there's no difference between chlorhexidine and oil. We then got bleeding on probing, and then the bacterial colony count. So Streptococcus mutans, this is the major pathogen or the major bacteria which initiates dental decay and periodontal disease or gum disease. One study in particular looked at the number of Streptococcus mutans. They found that there was no statistical difference for both the oil and the control group. And it was similar in the 2 studies that looked at the salivary bacterial colony count. Basically, they found that using coconut oil didn't significantly reduce the amount of bacteria within the mouth. But the studies demonstrated that they did reduce the indices, so the bleeding on probing, the gingival index, and the plaque index. In terms of the quality of the studies and the risk of bias, there was a significant variation in the presence of bias within all of the 4 studies. So due to the very nature of the intervention, I mean, coconut oil has a distinct taste and a consistency. So study subjects were likely to know that they were using coconut oil and not the control. Unless they did a double-blind crossover study, it's very difficult to assess this. So bias is high. Selection bias was also high in a number of them. It was unable to determine whether the groups had been concealed adequately. All of the RCTs were deemed to be low quality purely because of the lack of statistical analysis. So we can't be confident that the results of these interventions are near the true values, the outcomes, but it is promising. And I think all of the results that we've got here do demonstrate that there is evidence that using coconut oil has a significant effect on plaque index scores when compared to a control group. In terms of the bacterial colony count, we already know that the biofilm is structurally complex, and it's very difficult to manage that once it's formed its ordered structure. So coconut oil is unlikely to be able to remove that. You still need that mechanical intervention. But in terms of the plaque adhesion and the initial adhesion of the biofilm, it can be very effective at doing that. And it's promising that coconut oil had a very similar benefit to the chlorhexidine digluconate, which is currently considered the gold standard in terms of therapeutic chemical management of oral hygiene conditions. So obviously there are some limitations to this systematic review, even though we adhered to the PRISMA guidelines. Firstly, due to the small sample size and the short duration of the study, it's unclear whether these results can be extrapolated and applied to the long-term beneficial effects of using coconut oil. Also, 3 of the studies were conducted in India. So it may be that within this continent, we can't then generalize the findings to other regions. And the very nature of the differences in the inter-study methodology, the quantitative pooling results, it was unachievable. So the distinct correlations and corresponding conclusions, we can't really make them. And despite the measures in place to avoid bias within these studies, like I said, owing to the very nature of the interventions with coconut oil, having a distinct taste and color and consistency, complete subject blindness is difficult. And so with both selection and performance bias, it's difficult to get non-misleading results. And it may be that there are other RCTs out there that haven't been published or that we weren't able to find So another limitation. But in terms of the implications, it is difficult to determine whether oil pulling coconut oil has an actual beneficial effect. It is promising to see the studies that have beneficial outcomes, and I hope this review will encourage further research into a higher quality of evidence in the future. And as I can show you on the screen, these are just 4 products that are already on the shelves in the UK. And these are coconut oil mouthwashes. Consumers will want to know whether these are effective and valuable in the prevention of periodontal disease and dental caries. They're definitely more effective than a lot of the mouthwashes that are already out there, but there's no strong evidence to support them. So I think that more studies are needed to determine whether it improves oral health. And when they're undertaken, they should be carried out in multiple centres with a large population. The outcomes need to have standardised, reproducible scales, and they need to be calibrated amongst the clinicians that are then involved in the study. They need to be able to describe the assessment in sufficient detail and also have common and quantifiable, clinically relevant data included within the study design. I think it'd also be beneficial to see it over a longer term rather than 2 weeks. It's just not enough. Inflammation takes about 6 to 8 weeks systemically to reduce in the mouth. It can take a little bit less time, but you won't be able to see the true results unless you do it over a long period of time. So I'd just like to say thank you to everyone who contributed to the systematic review. There were no conflicts of interest when we carried it out. Again, there wasn't any funding from any sources. It was all carried out in-house. And there's some references here for a few of you if you want to go away and look at it. But I'm greatly appreciative for all of you for logging in and spending your time, whatever time zone you're in. And I know you're probably all waiting to get on to lunch, dinner, breakfast, and more presentations, but I'm more than happy to answer any questions that you may have.